Great. I hope everybody can hear me. It's been a while since I spoke to everybody. How are you and how is your family doing? I can't believe that it's already February and it's been a really long winter because of COVID and Omicron strain and related issues. But I think, as things are getting better, you're beginning to see the light at the end of the tunnel. And I just want to begin today by just expressing my gratitude for all your resilience and dedication in care and for our patients. Back to the grand round. Today is a special grand round. It's the fifth Henry Nasrallah lecture. This end of the lectureship is a gift from our very special friend, Dr. Henry Nasrallah and his family. Dr. Nasrallah is a widely recognized neuropsychiatrist, educator, researcher. He did his psychiatry residency at University of Rochester and neuroscience fellowship at NIH. And after that, he has a very distinguished academic career as a chair of psychiatry at two universities and associate dean for another 4 years. And he is right now at University of Cincinnati as a professor of psychiatry. And today's speaker was recommended by Dr. Nasrallah. And for those who do not know the history between Cincinnati and Rochester, John Romano and George Engel was at Cincinnati together for several years before they were recruited to University of Rochester in 1947 to start our department, which relates to our 75th anniversary that we're going to celebrate this year. And hopefully Melissa and Dr. Nasrallah and everybody will be also able to join the celebration. And in relation to that, I also wanted to make a quick announcement that we have 75th anniversary webinar series, Romano and Engel, a personal look at our founders that will be done on February 8th at 6 p.m. So we'll send out more announcement related to that so people can join the special event. Now, I still have to go through a little bit more, sorry about that, Melissa, in relation to some of the housekeeping items before I introduce the speaker. Microphones and cameras are off except for the presenters, interpreters. Use your Q&As related to questions rather than the chat box. And I'll ask your questions to speakers during the Q&A portion at the end of the talk. And we'll have an opportunity to provide us with feedback and receive C credits through a link to the chat, and there will be a link at the end of the presentation as well. And the email will be also sent out as well with a link. Now, finally, let me introduce today's speaker, and I promise, Melissa, that I'll be as brief as possible, but it's really hard to summarize her CV. Dr. Melissa DelBello is the Dr. Stanley and Mickey Kaplan Professor and Chair of Department of Psychiatry at the University of Cincinnati. She received a bachelor's degree from Cornell, and I found out today that she and I were actually classmates at Cornell. And I don't remember seeing her, but I'm sure that we were in some classes together as pre-meds. And after Cornell, she went to medical school at University of Rochester. So this is another connection to us. And later, she also received a master's degree in epidemiology and biostatistics at the University of Cincinnati. Dr. DelBello also did her psychiatry residency at University of Cincinnati, and then she also did child psychiatry fellowship at Children's Hospital Medical Center, and did her 2 years of research fellowship at the same institute at Bipolar and Psychotic Disorder research program. And she joined the psychiatry faculty at University of Cincinnati College of Medicine in 2000. And over the years, she has risen through the faculty ranks and a variety of leadership roles until in 2014, she was appointed the professor and chair of psychiatry at the University of Cincinnati. She has had a stellar, distinguished research career as the expert in the psychopharmacology of all age range, but particularly in childhood onset mental illness especially in bipolar disorder. As a resident and as a trainee, and even now, I read her landmark studies over the years, and she is the final word in relation to bipolar disorder, natural course and treatment and idiopathogenesis among children. And this is really a treat for all of us who are attending this. She's been continuously funded. She has been involved in 50 plus clinical trials as PI. She has published 300 plus articles over the years and served in numerous journal editorial boards. She is also is a recipient of many distinguished awards, most notably Presidential Scholar Awards, Outstanding Mentor Awards, Robinson Cunningham Awards from the ACAP, and also very dear to our heart, National Alliance on Mental Illness Exemplary Psychiatrist Award as well. So, it's such a great pleasure and honor to introduce Dr. DelBello, who will give a talk titled Youth at Risk for Bipolar Disorder.
Thank you. Thank you so much, Dr. Lee. That was a very kind introduction. I'm not sure I'm the final word in anything, so, but hopefully we'll kind of cover some ground looking at children who are at risk for bipolar disorder. I also want to thank Dr. Nasrallah, who's been a great mentor here in Cincinnati, and I'm honored to be presenting at the lecture for which he supports. So thank you for inviting me. So without further ado, let's get started and talk about children at risk for bipolar disorder. Wanted to disclose financial affiliations. Won't really be talking much about medications today. As everyone saw before, the learning objectives, first we'll talk about the clinical presentation of children who are at risk for bipolar disorder. And then we'll talk a little bit about clinical and neurobiological risk factors. And then we'll talk also a little bit about treatment strategies and how we've combined treatment strategies with imaging to kind of predict who might be responsive to what type of strategy for intervention. So I think before we start, it's very important to all be on the same page about what we are meaning when we talk about a prodrome or early offspring of bipolar parents or at-risk kids. So I think the prodromal concept is something that's been studied probably more so in psychosis and schizophrenia, but in bipolar disorder, it has been sort of behind the psychosis world, and that it's a hard concept, or harder concept to figure out what is the prodrome to bipolar disorder. And is bipolar disorder in people who are at risk the onset of their first depressive episode, their first manic episode? But do we have a defined prodrome in bipolar disorder? And again, it's kind of a retrospective concept in that you have to follow people who you think might be at risk and then look back and figure out what were the early manifestations and what are risk and resilience factors to help define the prodrome. So in effort to kind of clarify what we think the prodrome for bipolar disorder is, we're going to review some of the early manifestations and the clinical risk factors that we know might be associated with the onset of bipolar disorder. So the greatest risk factor that we know is having a family history of bipolar disorder. And in fact, it's very specific for bipolar disorder. As opposed to major depressive disorder, having major depressive disorder in a child or adolescent, the rates are fairly similar if you come from a family that has bipolar or major depressive disorder. Whereas really the rates, having a family history of bipolar is one of the most specific risk factors for developing bipolar disorder. And so when we look at risk factors and defining a prodrome, basically we start typically with family history of bipolar because we know that is consistently the greatest risk factor. But that alone is not enough because most children of bipolar parents will not go on to have bipolar disorder. And so we need to sort of narrow that definition of a prodrome. And we can do that looking at multiple different risk factors, specifically what types of psychopathology are present in these high-risk kids, and what, besides what type of psychopathology is present, what is then the risk for developing bipolar in that child. So just because, as we'll talk about, just because a disease or an illness is more frequent in children who have parents with bipolar doesn't mean it's necessarily a risk factor for prospectively going on to develop bipolar disorder. And then there are neurobiological, neurofunctional, neurochemical, different risk factors that you can use to kind of fine tune the prodrome, and then other environmental risk factors as well. So we'll kind of touch on some of the neurobiological ones as well as the psychopathology. So we're going to look at some of the data from the BIAS study, and this is the bipolar offspring study that Dr. Bermerher from Pittsburgh was the main site and the PI for. And so we're going to look at some of those data because the psychopathology of bipolar offspring, really a lot of our information comes out of the BIAS studies. And so this was a study that looked at children of parents with bipolar disorder as well as control offspring. So the control offspring consists of offspring of healthy control parents without any psychopathology, as well as offspring of parents who have psychopathology that's not bipolar disorder. So it's a mixed comparator group that has also some risk associated with it because the parents, not all the parents in the group are healthy. But regardless, when you combine those kind of two groups of comparators, what you see is that there are significantly higher rates of anxiety disorders, ADHD, any mood disorder, disruptive behavioral disorder, bipolar spectrum disorders, and depressive disorders in these school-age children. And then when you longitudinally follow them over time, what you learn is that specifically anxiety, ADHD, substance use disorders, and disruptive behavioral disorders are significantly greater. And this is over time. The important factors here is that when you follow these kids over time, you start seeing subthreshold manic symptoms and hypomanic mixed episodes. And those are significantly greater in the bipolar offspring compared to the comparator group. And rates, up to 15%. Importantly to notice is that major depressive disorder, there is no statistically significant difference in rates between the bipolar offspring and the control offspring. So looked at a different way, we can look at the two different control groups and the odds ratio of developing psychopathology in the group that is the offspring of parents with bipolar disorder versus the offspring of control parents who have a psychopathology but not bipolar psychopathology. And that really can help us know what is specific to having a parent with bipolar versus a parent with other types of psychopathology. And in fact, having any Axis 1 disorder, there's really not much of an increase, maybe double the rates, but not hugely compared to healthy offspring where there's 4 times the risk. But most importantly, having bipolar spectrum disorders, you have 9 times the risk if you have a parent with bipolar compared to a parent with other types of psychopathology. And these are, again, young kids ages 7 to 17. So the risk is high when they're young. Again, the risk of depressive disorders may be slightly higher, but not significantly higher. And anxiety disorders are very high in this at-risk group as well. Again, the risk factors, the highest risk factor is family history of bipolar, and then high rates in school-age children of anxiety, ADHD, disruptive behavioral disorders. And then when you follow those kids longitudinally, you see the risk is high of subthreshold manic symptoms and hypomanic mixed episodes. Again, depression doesn't seem to be significantly greater in the bipolar offspring. And then this is the odds ratio. So please interrupt me if you can't see the slides. The risk is greater, particularly of anxiety and bipolar spectrum disorders, not really so much for depression and ADHD. So what does that mean in terms of developing bipolar disorder? So just because the risk is greater, like ADHD, the risk is greater in the bipolar offspring than in the healthy control offspring, but consistently ADHD does not seem to predict who's going to go on to develop bipolar disorder. But there are specific factors that have been shown in the BIAS study and other studies to be associated with risk of developing bipolar disorder in the kids who have parents with bipolar disorder. And there are parental factors such as having early onset bipolar disorder in the parent. There's younger parental age during the time of the child's birth, and a bilineal family history. So having both parents with bipolar disorder increases your risk about 40-fold to have bipolar diagnosis during young adulthood. Similarly, there are factors in the child that are associated with developing bipolar disorder. So depression and anxiety, although depression in and of itself is not higher rates in the youth who have bipolar parents, depression and anxiety symptoms are shown to be risk factors for later going on to developing bipolar disorder, and mood lability and subclinical mania. Older age of the offspring, which sort of makes sense because they go through the risk of developing bipolar disorder, exposure to antidepressants and stimulants. And we'll talk a little bit more about this later, whether it's a cause or an effect. Are these people who just have higher rates of ADHD, higher rates of depression and anxiety? It seems not to be the case, but exposure to antidepressants and stimulants is associated with risk of developing bipolar disorder. And then anxiety and disruptive behavioral disorders have been associated with going on to develop bipolar disorder. So what is ADHD in these high-risk offspring? They're present, it's something we see a lot. It brings these kids to clinical attention a lot. And there are higher rates of ADHD in study after study in the offspring of parents with bipolar disorder compared to the control offspring, the healthy control offspring. But there's no difference in the course of ADHD between the two groups, and except what you see is greater comorbid mood and anxiety disorders in the youth offspring of the bipolar parents. So we'll talk about a little bit when we talk about the imaging what we think ADHD is in these high-risk offspring. It may not actually be what we think of as typical ADHD. It may be an early manifestation of mood symptoms and compensatory neurobiological mechanisms that are trying to stabilize mood. But we can talk more about that later when we talk about some of the imaging findings. And in fact, ADHD does not predict in and of itself developing a bipolar disorder. But there are higher rates of mood and anxiety disorders when their mood and anxiety disorders are present with ADHD. That does go on to predict developing bipolar. So those are some of the risk factors and clinical manifestations. We talked a little bit about depression. And so depression in and of itself is not higher in children who have bipolar parents. It is than children who have parents with other psychopathology. But specific types of presentations of depression have been associated with greater risk of developing bipolar disorder. And sometimes you can look at a child who's at risk of having a parent or several first-degree, second-degree relatives with bipolar, and by characterizing their depression by some of these characteristics, clinically, I think you can kind of tell if they're at risk for developing bipolar disorder. So it kind of seems my clinical experience is consistent with some of these data. But rapid onset, psychomotor retardation, the presence of psychosis, multi-generational family history of bipolar disorder. It used to be treatment emergent hypomania, which now the child would obviously by definition have bipolar disorder. But then there's a more recent analysis that looked at the nature of the depression in the bipolar offspring who had depression versus the non-bipolar offspring who had depression. And it was a more severe depression, a lot of hypersomnia, and more mixed depression, so more irritability, racing thoughts. And in contrast to depression, which rates obviously are higher in pubescent females, there's equal gender distribution in the offspring of parents, because probably it's predictive of who's going to go on to develop bipolar disorder. So looked at another way in terms of the progression of mood disorders and bipolar disorder, we think initially anxiety, sleep disturbance, early manifestations, extreme irritability is also one. And then comes on the major depressive episode, recurrent depression, and then bipolar 1, bipolar 2, and schizoaffective bipolar. So it's sort of the psychopathology that goes on to predict who's going to develop bipolar disorder. Something I wanted to call your attention to that has some utility more as a clinician, not necessarily to share with patients yet, but there are 2 risk calculators that have been developed predominantly by the Pittsburgh group, but validated by other groups. And risk calculators, again, is not something we've used a lot in bipolar disorder, but is something that has been used in other types of psychopathology, schizophrenia, again, and they are used to predict the likelihood that somebody's going to go on to develop bipolar disorder. And there's 2 different risk calculators, and again, I invite you to look at the website, and one of them is looking at high-risk offspring, so again, offspring of parents with bipolar disorder, and looking at the risk of developing bipolar, other specified bipolar, not otherwise specified, the kind of spectrum of bipolar disorders. That's one risk calculator, and then the other risk calculator is looking at this subsyndromal kind of bipolar, not otherwise specified, and their conversion to developing bipolar 1 and bipolar 2. So they're pretty helpful because, again, they use risk factors to predict who's going to go on to develop these illnesses. There's a recent analysis that has tried to validate these risk factors and the risk calculator. And what they found is that they actually do better without the semi-structured diagnostic interview, which is reassuring because that limits the clinical utility of the risk calculator, because most clinicians don't do semi-structured diagnostic interviews as part of their assessment. And so actually without it, the risk calculator has better predictions. And so I think as we get more and more data, they will become very helpful. So this is how we kind of view the stages of the progression to bipolar disorder. The first is looking at risk factors or markers of illness. Then prodromal clinical features, what we consider ADHD, like I said, is kind of more mixed, but the anxiety, depression, hypomania, and the anger and irritability. And then, of course, the onset, stage 3 of developing a manic episode and bipolar disorder. The risk factors and markers have been looked at in various studies and are fairly consistent. And we'll talk about some of those as we talk about interventions. But moving towards intervention, you might imagine, depending on whether just risk factors are present and or if there's types of psychopathology, you might be more aggressive or less aggressive depending on the type of treatment. We're not at primary prevention yet. We don't really have those strategies yet. We're talking more when we talk about intervention studies, early intervention during one of the prodromal manifestations of bipolar disorder, or what we think will go on to develop bipolar disorder. So we're really going to be talking about early intervention studies as we talk about intervention. And I think it's really important to talk about the ethics of early intervention, because you're sort of treating something that you really don't know what it's going to end up being. And there are side effects of medication. So you want the most benign side effect profile, especially as you're treating subsyndromal symptoms or even just risk factors. So you're going to have to take that into consideration. The benefits outweigh the risks. So you want something that treats the clinical manifestations at the time, but you also want something that's not going to precipitate the manic symptoms, not precipitate irritability, not worsen the risk or accelerate the risk. And you have to also realize that just based on psychopathology, we don't have consistent biomarkers at this time, but hopefully, as we'll talk about, combining some of these clinical early manifestations with biomarkers might kind of help us predict who's going to go on to develop the illness. But even if we look at children who have bipolar parents who are present with depression and have a lot of the clinical manifestations of their depression that we discussed, not all are going to go on to develop bipolar disorder. And so we need help. We need more markers of who will be likely to go on to develop as we talk about treatment. And so with that said, there have been some studies. The problem with a lot of these studies that, we did some of them is that we really don't have a good definition consistently to compare one study versus the other. And some of the studies are double blind. Some of them define at risk one way. Some of them have outcome measures different from other outcome measures in different studies. So the first and earliest studies was quite a while ago that Barbara Geller did looking at lithium, and it was a double-blind placebo-controlled study in children who had parents with bipolar disorder who they themselves had depression, and lithium was no more effective than placebo in this population. Then a couple of studies looking at DelBello, an open label study that defined at risk as a wide variety of disorders, ADHD, depressive disorders, cyclothymia, and having a parent with bipolar 1 or bipolar 2. That was an open label study, showed some suggestion that maybe DelBello was effective. And then Dr. Finling did a double-blind placebo-controlled study that showed only if you had a multi-generational family history with 3 or more family members with at least emotional dysregulation was DelBello more effective than placebo. And so a very small subsample that might be useful to predict who might respond to DelBello. Quetiapine, we did an open label study in youth who had major depressive disorder, dysthymia, basically any mood disorder that wasn't bipolar disorder, and a bioparent with bipolar 1. And we did see a very high response rate, but weight gain and sedation was pretty ubiquitous as a side effect. And then aripiprazole has been studied and has been shown in the bipolar not otherwise specified group of young kids who had first degree relatives or second degree relatives with bipolar and a parent with bipolar, or first and second degree relatives with a mood disorder, and it was more effective than placebo. In this population, weight gain was also a significant concern, but some suggestion that perhaps some of the SGAs may work in this population at risk, but very, very preliminary data. So then there's non-pharmacologic interventions. Obviously, in general, these have lower risk profiles and can be useful for the right patient. The two modalities that have been studied the most in this high-risk offspring population is family-focused therapy, which is David Miklowitz's intervention that combines like a psychoeducational family approach. It has 12 one-hour sessions on communication training and problem-solving skills over the course of 4 months. And what you can see down here below is that family-focused therapy was more effective than enhanced care to prevent having a mood episode, a full-blown mood episode. And then mindfulness-based cognitive therapy, which we and others have had a great interest in. And particularly, it's a group therapy, 12 weekly sessions, and it's manualized. And it combines mindfulness practices with CBT kind of practices. And so you recognize the relationship between feelings and thoughts, and you don't challenge them, rather you make a choice to decenter from them or separate yourself from them. And that's been shown in a high-risk group with anxiety disorders to be highly effective to reduce anxiety in this population. And we'll talk about some of our imaging findings from that study later on, but some of the most striking imaging changes from mindfulness-based cognitive therapy. So some suggestion that in these at-risk kids, whether they have mood disorders in the family-focused therapy or anxiety disorders, that non-pharmacologic interventions may be effective and quite well tolerated. So what about antidepressants? This has been somewhat controversial. Do we treat kids who present with depression and a bipolar parent with an antidepressant? This was a naturalistic study that we did looking at our large cohort of at-risk kids and those who presented with depression or anxiety and were treated with an antidepressant. And again, it's a naturalistic study, but what we found was that 57% of these kids who were treated with an antidepressant for anxiety or depression had a serious adverse event. Serious adverse event meaning were hospitalized, were psychotic, were suicidal as a result of being tried on the antidepressant. It was typically when it was initiated or when a dose was increased. There were no baseline clinical differences between the groups, but what was most predictive was age. So if you were depressed or anxious and had a parent with bipolar and you were age 9, you had almost 100% chance, if you were treated with an antidepressant, to have one of these side effects that led to discontinuation of the antidepressant. Whereas if you were 18, 19, 20, and you were treated with the antidepressant, you had a very little chance of having this adverse reaction. Now, obviously, what we don't know is, do the same kids who develop this reaction at age 9, are they going to be the ones who develop it at age 20? But we just don't have longitudinal data at this point. But regardless, most 8 to 10-year-olds who have depression or anxiety who are treated with an antidepressant will have a bad reaction to that antidepressant. So how do we figure out who these people are going to be, and what type of neurobiological markers can we use to better discern those who are at risk and those who are more likely to have antidepressant-induced side effects? So we've used a variety of imaging strategies to look at this. And so just in summary, I'm going to try and briefly summarize some of the findings, but some of the most prevalent findings in children who have bipolar disorder are abnormalities in ventral prefrontal development, abnormalities in connectivity between the ventral prefrontal regions and the amygdala. And so you would guess that we might look at some of these regions in the kids who are at risk for bipolar disorder and see if some of them are present. And can we use some of these known abnormalities in kids who have bipolar disorder to predict in the offspring who's going to go on to develop? And so what we've consistently as a field found is that the structural amygdala findings that are present in the kids who have bipolar disorder are not present prior to onset of illness. However, when you look at functional findings and functional connectivity between these prefrontal and amygdala regions, what you see is that those changes are present in the offspring sample, as well as neurochemical alterations in the prefrontal regions. Very consistent with what is found in those who already have their onset of bipolar disorder. And so maybe we can use some of these markers to kind of predict, in conjunction with other clinical manifestations, who's going to go on to develop bipolar disorder. Now, we have to balance that a lot of these kids already have different types of psychopathology. So if you get a group that has of offspring that has no psychopathology, you're likely looking at a group that's more resilient to developing bipolar disorder, which is not the group you want to use to identify biomarkers. In contrast, though, when you take all comers, you get a lot of heterogeneity of the psychopathology in the offspring, and so that kind of confounds some of the data. So those are kind of some of the limitations that we're struggling with as a field. I wanted to highlight one study because I think this study nicely depicts some of the most consistent findings in the at-risk group. So this study compared offspring of bipolar parents, the BO group, to offspring of parents with psychopathology, non-bipolar psychopathology, the NBO group, and then healthy controls who had no first-degree relatives with any mood disorder. And what you can see here is that amygdala activation during this task, which is looking at emotional stimuli, happy or negative versus a shape. And what you can see is that the offspring of bipolar parents look very similar to the offspring of non-bipolar parents with other psychopathology. And they both have increased amygdala activation compared to healthy controls. In contrast, when you start looking at connectivity between the amygdala and the anterior cingulate, or the amygdala and the ventrolateral prefrontal cortex, you start seeing some very specific differences between the offspring of bipolar parents, which what you can see is there is decreased connectivity between the right amygdala and the anterior cingulate compared to the other groups, and increased connectivity between the right amygdala and ventrolateral prefrontal cortex when viewing happy stimuli compared to the other two groups, that you see the normal reciprocal connectivity. So decreased connectivity when we know that the ventrolateral prefrontal cortex inhibits the amygdala, and so you expect to see that decrease in healthy controls. You see actually an increase in the offspring of bipolar parents. So again, some of the most consistent findings, I'm just using one example of a study that's been done that nicely has two comparator groups. So another study that has looked at prefrontal amygdala connectivity in low risk and high risk youth, and the high risk youth have a parent with bipolar disorder, and this looked at reward processing, so positive reward versus loss or negative punishment kind of task. And what you see is that the high risk kids have abnormal connectivity during both reward and loss or punishment. And so they look different in terms of the way their prefrontal cortex is managing their connectivity between the prefrontal cortex and the amygdala. So again, some indication that there is abnormal connectivity. So for the last few minutes, I just wanted to touch on some of the studies and the highlights from our at-risk cohort. So we have an at-risk cohort of about 120 kids who have a first-degree relative or parent with bipolar disorder. And our goal of looking and characterizing this population was to figure out what neurobiological abnormalities are present initially, and then follow them over time and figure out when they develop a mood disorder, what changes occur, and then could we have predicted at baseline who's going to go on to develop a mood disorder. And one of our studies that I enjoy, one of the most compelling studies, in my opinion, is we did have over the initial course of 4 years, 19 kids who developed a mood disorder, a major depressive episode or a manic episode. And we looked at this group compared to a matched 19 offspring who did not develop a mood disorder. And so they had that at risk as well. They had a parent with bipolar disorder. They were matched in all demographic features. And we used neurochemical predictors, so magnetic resonance spectroscopy in the prefrontal cortex in 3 different regions, the anterior cingulate, the left and right ventrolateral prefrontal cortex. And we looked at different metabolites to see if at baseline, what differentiates those who are going to go on to develop a mood disorder compared to those who don't go on to develop a mood disorder. And we used a machine learning type of analysis. And what we found is that in particular, the neurochemical profile at baseline in the left ventrolateral prefrontal cortex of specifically for choline, creatinine, and myoinositol, which are all known to be neurochemicals known to be involved in membrane metabolism and second messenger signaling in the brain. And what we found is that those 3 neurochemicals predict with a lot of accuracy, as we'll talk about in a second, who's going to go on to develop a mood disorder. So as a region, left ventricular ventricular prefrontal cortex, ventrolateral prefrontal cortex predicts who's going to go on to develop a mood disorder. And then when you pull out those 3 different neurochemicals, you see that the sensitivity is about 84% and the accuracy is about 80% at baseline when these groups looked exactly similar, no difference in mood disorder, anxiety disorder. With 80% accuracy, you can predict, looking at those 3 neurochemicals, who's going to go on to develop bipolar disorder. Now, obviously, this is a small study and definitely needs to be replicated in larger samples, but is some indication that we can see some markers before the onset of the mood disorder. Similarly, we've used our at-risk sample to try and understand what ADHD is in these at-risk kids. And so we compared a group of bipolar offspring who had ADHD compared to offspring of parents who don't have bipolar disorder, who have ADHD, and healthy controls. And we're trying to understand, is this really ADHD similar to the low-risk ADHD without having a biological family history of bipolar disorder? And they look fairly similar, these kids, in clinical characteristics, the low-risk and high-risk groups. But when you start to look at the amygdala, ventrolateral prefrontal cortex functional connectivity, you start seeing that there are some differences. And, you wouldn't know because they have the same type of ADHD. And what you see is that in the left amygdala to right VLPFC, there are both the low risk and high risk look similar and different than the healthy controls. However, when you look at the right amygdala to right VLPFC, you start seeing some differences between the low risk and high risk. And this and some other data that we have from imaging has led us to kind of think, well, maybe ADHD in high risk youth is not the same ADHD that we know of in low risk youth. So we can use it to sort of understand what the early manifestations or what these kids who are more common in these at-risk populations like ADHD, what they look like is the same psychopathology, meaning the same thing. And we've also used imaging as a modality to try and predict the group that's going to go on to develop the side effects to antidepressants. Specifically, this is a study looking at baseline, the group before they went on to have the antidepressant-induced manic symptoms, or the side effects as we're calling them. And what you can see is that before they were exposed to antidepressants, you can actually see some differences in connectivity of the right amygdala to the left medial temporal regions, as well as the right prefrontal cortex. And so you can see at baseline who might be at risk for developing this side effect. The next step, these are in groups, and the next step is actually to look at, and this is a study that we're almost done with, look at some of these findings and see if at baseline in a prospective study that's controlled, you can see who's going to go on to develop the side effects of having antidepressants. So if somebody presents with depression or anxiety, you can avoid going to an antidepressant first if they have a certain neurofunctional profile. So lastly, I just want to mention two studies that we have done looking at omega-3 fatty acids. And we know that kids who are at risk for bipolar disorder and those who have bipolar disorder have lower levels of omega-3 fatty acids. That's been shown in several studies, whether they have depression, the ultra high risk group, or bipolar disorder, or just are in the group of bipolar offspring compared to healthy controls, they have lower rates of omega-3. And so we did a double-blind placebo-controlled study looking at omega-3 versus placebo in looking at change in depressive symptoms and overall clinical global response. And what we found is that there was a trend to showing improvement, overall improvement in the omega-3 group versus placebo was non-significant. We did get an increase in omega-3 in the group that was taking omega-3, which was reassuring in their blood samples. And what we also found was looking at some of the imaging before and after, that we did see some changes that were specific to the group that took the omega-3s, particularly in connectivity of the orbital frontal cortex with the superior temporal gyrus and the amygdala to the inferior temporal gyrus. And the amygdala inferior temporal gyrus findings actually in the omega-3 group correlated with the change in depressive ratings and overall global functioning. And so there is some indication that for the specific group that might exhibit these abnormalities in amygdala inferior temporal gyrus connectivity, that omega-3s may be particularly helpful. And finally, with our mindfulness-based cognitive therapy study, we also found some of the most striking findings, I think, is that we saw that pre and post mindfulness-based cognitive therapy, we saw an increase in activation in an emotional task, like showing emotional stimuli. We saw an increased activation in the bilateral insula, the left anterior cingulate. Those are the two regions I want to highlight. And that the increase in activation was associated directly, significantly, with the decrease in anxiety that we saw in this group. And that at baseline, lower activation in the left anterior insula, the left anterior cingulate, and the right anterior insula significantly predicted who was going to have improvement in their anxiety rating scale scores. So again, using some of the imaging combined with the treatment studies, we're able to personalize potentially who with what neurobiological findings and what clinical manifestations may be most likely to be to respond to what type of treatment. And that is our hope, and that, you know, we can start with stage 1. We may be more willing to use you know, different types of intervention that are more benign. So omega-3 fatty acids, if they have low omega-3s, we might use FFT or mindfulness-based cognitive therapy, or other types of vitamins that have yet to be studied. But when they hit stage 2, that's when we have to be really careful, because as we're learning, some medications may make or accelerate the onset of developing manic symptoms. And so you have to kind of keep that in mind as you treat them, as they're kind of developing what may be a prodromal manifestation, particularly if there's depressive symptoms, manic symptoms, anxiety symptoms. So in conclusion, I hope that we've conveyed family history is the greatest risk factor for developing bipolar disorder in children and adolescents. They're at risk for developing a wide range of psychopathology, but only some types of that psychopathology, manic symptoms, depressive symptoms, anxiety, predict who's going to go on to develop bipolar disorder. And we need to refine, replicate some of the biomarkers to go on to figure out how do we combine some of those clinical manifestations with the neurobiological markers. Potentially, we haven't talked much about genetic biomarkers. So how do we combine all of these to enhance the risk calculators that are predominantly based on clinical manifestations? So with that, I want to thank all of my collaborators and NIMH who supported most of our work. So thank you.
Thank you so much, Melissa, for a wonderful, comprehensive talk. And it's wonderful to see the field moving toward identification of biomarkers to identify the at-risk use even better. And there's, we have a few minutes for questions. So let me just quickly ask you a couple of questions. There's this also concept or diagnosis of disruptive mood dysregulation disorder. And is that like a early form of bipolar disorder, or is it a related form? Do you have any thoughts on that?
So I don't think we know exactly. And I think that the diagnosis is used very inconsistently. There's a lot of criteria for DMDD, but it is in the depressive spectrum of illnesses. And so I think the problem is that in most of these studies, really not many people are diagnosing DMDD in these at-risk kids. When you look at a group of DMDD kids, they have very low rates of family history of bipolar disorder, which kind of suggests that maybe their trajectory clinically is very different than those who are going to go on to develop bipolar disorder. So I would say probably not with the current evidence that we have.
Got you. And there's another question about, I think that the biggest challenge for clinician is that as we rely on phenotypes of these patients for making good diagnosis. Could you speak a little bit more to the difficulty of confirming an accurate diagnosis of bipolar disorder versus other disorder like ADD in this particular population?
Yeah, so I think in the parents, it's very difficult, particularly if the parent isn't there and you're kind of relying on an ex-spouse of the parent or the in-laws of the parent who was diagnosed with bipolar. It can be very difficult. And most of the studies that we talked about have used structured diagnostic instruments to figure out and medical records in most cases to figure out who's had bipolar disorder as a parent and who's, possibly had a substance use disorder or ADHD. But it can be very difficult to figure out. I think the goal is to get as much information as you can, reactions to antidepressants, comorbid substance use, but if there's a mood component, trying to talk to their parents, so the parent of the parent who might have bipolar disorder can be very helpful getting medical records. But yes, it can be very difficult.
Maybe one last question before we close. I mean, in our department, we put a lot of efforts developing prodromal psychosis, at-risk psychosis clinic to really identify people early. But this is based on the notion that early intervention changed their overall trajectory of their care. Are there similar evidence that's now developing in bipolar disorder relates to how the early identification and treatment improves the trajectory or the history? Yeah.
So I think we're just starting to get some of those data. There's some evidence that omega-3s might improve the trajectory. The difference, I think, with psychosis is that we see a lot of different types of psychopathology that's present earlier in these kids who are at risk. And so while we also want to change the trajectory, we also need to treat what we're seeing now. And so we have to just kind of strike a balance between that.
Great. Well, thank you so much for the wonderful talk. I certainly learned a lot, and it was great to see you. Hopefully we'll have an opportunity to invite you in person in the near future. And so thank you so much. And thank you, Dr. Nasrallah, for providing us an opportunity to have this wonderful lectureship. Otherwise, hope everybody has a great day and take care. Bye-bye.
Thank you.